Hello, my name is Jessica Fellinger, and today I'm going to be talking about my major case study. To protect the identity of the patient, I'm going to be calling him Patient A. So Patient A is a 35-year-old male who is 6 feet tall and 74.8 kilograms at admission. So he started his admission with a BMI of 22 on January 14th. He came in through the emergency department complaining of abdominal pain as well as some chronic leg wounds. He said that he had not been eating for the past 3 days prior to coming to the emergency department. He said that his wounds had been present for several years, and that in addition to his abdominal pain, he also had nausea and vomiting. He denied diarrhea at the time and said that his urine looked brown. He also said that he smoked half a pack of cigarettes daily, and he appears older than stated age. The initial physician exam in the emergency department showed that the patient was tender to palpation of his abdomen with hypoactive bowel sounds. So his bowel sounds were lower, less than what we would normally expect for a healthy person. The results showed from the blood work that the patient was septic, and the scan showed that the patient had a perforated appendix as well as peritonitis, so his whole peritoneal cavity was inflamed. The general surgeon was consulted at this time, and the patient was taken to the operating room for an exploratory laparotomy. The surgeon performed this exploratory laparotomy, and they removed 500 cc's of foul-smelling fluid from the patient's abdomen. The surgery also showed fecal contamination of the cavity and a large pocket of abscess fluid, in addition to the appendix that was removed. And this appendix was ruptured, so that was causing the infection in this patient. The charting from the next day, so January the 15th, shows that JP drains were placed and had serosanguinous output. An NG tube was placed, but not for feeding, only for suction at this time. And the NG tube drained 500 cc's of bilious output overnight. The leukocytosis appeared to be resolved and acute renal failure was improving. They planned to continue broad spectrum antibiotics for the infection, as well as fluid resuscitation because the patient needed fluids, as well as bowel rest because he had just had this major surgery. And for his labs, he had a creatinine of 2.7, which is a little high. He had acute renal failure that was improving at this time on the day after surgery. He also had an albumin of 2.5, which the albumin is a bit of a tricky lab value because it does show malnutrition, but it also shows inflammation, which with surgery, you're going to have inflammation. So his albumin was 2.5. He also had a white cell count of 19 and a hemoglobin of 9. So his hemoglobin was a bit low, but that can be expected. He had that ruptured appendix, the abscess, the surgery, so he had lost some blood.